has iron deficiency. You call a male with no FE. Once my colleague came to work and I noticed that his shirt was a bit creased. So I said, hey, what happened, man? Why is your shirt creased? He said, no, he's got iron deficiency. You know, iron. And what do you get when you mix calcium with iron? You get cafe. Hello everybody, Dr. Ryan here. I hope you and your family are well. Thank you so much for joining me even as we navigate through the world of anemia today. I strongly encourage you to subscribe to my channel so you don't miss any exciting upcoming content. Here's an outline of what we're going to be chatting about today. We're going to be introducing the concept of anemia and then introducing the truckload of etiologies behind it. We're going to be looking at a plausible patient presentation in terms of signs and symptoms, and then a differential diagnosis. Diagnostic evaluation in terms of working up a patient with anemia in terms of investigations. Then we're going to clarify treatment and management modalities, prognostication, complication, and as always, enclose with a scripture from the Bible. God bless you. Thank you so much for joining me and for subscribing to my channel, enjoying my videos. God bless you. We've got a 38-year-old woman today with a history of inflammatory bowel disease. Oh dear. Complaining of worsening fatigue over the last 1 to 2 months. A gastrointestinal disease has been stable for the past year on infliximab. If you remember, infliximab, we said in previous videos, was a TNF-alpha, tumor necrosis factor alpha monoclonal antibody. Is an inhibitor of TNF. Physical examination unremarkable, including heme-negative stool, very important negative. A hemoglobin has fallen from 11 gram per deciliter down to 8 gram per deciliter since last checked 6 months ago. Additionally, her serum iron and ferritin, which were both normal 6 months ago, are now low. Her blood smear is shown on the next slide. Let's have a look. Let's gaze at that for a bit. Alrighty. So what's happening, guys? What's the most likely etiology of a new anemia? Is it A, folate deficiency, B, inflammation, C, iron deficiency, D, sideroblastic, or E, vitamin B12 deficiency? Alright, guys. Anemia is a state of circulating erythrocyte, which is otherwise termed red blood cell, deficiency. It is assessed by measuring your hemoglobin concentration or hematocrit level, which speaks to the percentage of whole blood volume occupied by the red blood cells. That's hematocrit, right? Now, the World Health Organization criteria define anemia as hemoglobin or hematocrit that is greater than 2 standard deviations below the mean. That equates in males for a HB of being less than 13 gram per deciliter, and in women less than 12 gram per deciliter. Anemia, remember, may be the underlying cause of a presenting complaint or may be purely an incidental finding on physical or lab assessment, all right? Let's look at etiology, epidemiology, and risk factors, guys. So upwards of 10% of people older than 65 are actually anemic. And there are 3 general etiologies of anemia. It could be accelerated destruction of red cells on the account of hemolysis, or loss of red blood cells on account of bleeding, or diminished production of red cells because of bone marrow failure or inadequate substrate to produce those red cells in the way of iron deficiency, folate, B12 deficiency. Now, the mean cell volume, the MCV, is used to evaluate the size of the red blood cells and is used to stratify the different etiologies. However, there can be significant overlap between these categories. So I'm sure all of us are familiar with microcytosis when your mean cell volume is below 80 femtoliters. And the common etiologies there is the mnemonic tails. T for thalassemia, A for anemia of chronic disease, I for iron deficiency, L for lead poisoning, S for sideroblastic, right? So anemia of chronic disease on the back of malignancy, connective tissue disease, chronic infection, TB, common harbinger, right? Then iron deficiency, latent cause, inherited hemolysis. The most common cause of microcytosis without anemia is thalassemia, all right? Then macrocytosis, when your mean cell volume is above 100 femtoliters, common culprits, vitamin B12 and folate deficiency, liver disease, myelodysplasia, medications like methotrexate, which causes folate deficiency, ARVs, especially zidovudine, hydroxyurea, alcohol, then of course hemolysis or blood loss with reticulocytosis. When your bone marrow is working overtime to replace your red cells, and the red cells that end up in circulation are big and immature, we call them reticulocytes. Normocytic anemia, the situation when your mean cell volume is between 80 and 100. Common culprits, acute blood loss, renal failure on account of lack of erythropoietin, among other causes, hypo or hypothyroidism, aplastic anemia, bone marrow suppression, Crohn's disease. Now, in patients who have G6PD, which is glucose 6-phosphate deficiency, Hemolysis and anemia can occur due to drugs, usually antiepileptic drugs, sulfur-containing drugs, fever, or infection. Cold agglutinin hemolytic anemia is most closely associated with our good friend mycoplasma infection most commonly, but can occur in the setting of lymphoproliferative disorders, infectious mononucleosis, which is Epstein-Barr virus-induced, and syphilis. Now, cold agglutinins are temperature-sensitive antibodies to red blood cells. Now, this is taken from Talley and O Connor. It is a beautiful table which stratifies the etiologies behind each of the different categories of anemia. So, broadly speaking, microcytic, macrocytic, normocytic, like we discussed. So, microcytic, right? Remember tails: thalassemia, anemia of chronic disease, iron deficiency, lead poisoning, sideroblastic. But iron, needless to say, is essential for heme production. So, chronic bleeding, most common cause, guys, genitourinary or gastrointestinal, right? So you want to do your pelvic ultrasound, you do want to do your pap smear, you want to evaluate what's causing it. If it's genitourinary, gastrointestinal, do your scopes, upper and lower scopes, and take it from there, right? Malabsorption on the back of celiac disease, and we covered this, right, in a previous video. I encourage you to go and have a look at that. Hookworm in the way of blood loss and pregnancy, right? Please note that dietary inadequacy in and of itself is really a sole cause for iron deficiency. Thalassemia minor, which is an abnormal hemoglobin, there's a problem with beta globin chain synthesis. Sideroblastic anemia of myelodysplasia, where there's iron incorporation into the heme moiety, is abnormal. Then long-standing anemia of chronic disease. Then the next big group is macrocytosis. We stratify this as being megaloblastic or non-megaloblastic. Megaloblastic just describes the macrocytes in the blood form, it's oval, versus non-megaloblastic, which is round. Okay, and the common culprits behind megaloblastic anemia is B12 and folate deficiency. B12 deficiency often due to pernicious anemia, tropical spree or bacterial overgrowth, ileal disease, common culprits being Crohn's disease or prior ileal dissection above 60 centimeters in length, fish tapeworm, more affectionately termed Diphyllobothrium latum, which masquerades in Scandinavia, and poor diet, right? But remember that your stores of B12 in the liver can last you about 3 to 4 years on its own. So you've got to have long-standing B12 deficiency in the diet to be vegetarian to manifest B12 deficiency. Folate deficiency is often due to dietary deficiency, especially among alcoholics, malabsorption, especially celiac disease, increased cell turnover like pregnancy, leukemia, chronic hemolysis, chronic inflammation, and antifolate drugs, notably methotrexate. You've got to co-administer folate when you give methotrexate, or else you end up B12 deficient. Other culprits, phenytoin and sulfasalazine. Now, non-megaloblastic macrocytosis, we speak to alcohol, cirrhosis of the liver, reticulocytosis on account of hemolysis or hemorrhage, hypothyroidism, marrow infiltration from whatever cause, myelodysplasia, and myeloproliferative disease, right? And the normocytic anemia are broadly categorized as bone marrow failure, anemia of chronic disease, and hemolysis, hemolytic anemia, which can be extracorpuscular, right? Bone marrow failure because of aplastic anemia, where the bone marrow is essentially fatty and empty, and drugs are important cause, especially phenytoin, indomethacin, sulfonamides, antineoplastics, chloramphenicol. Radiation can do that, lupus can do that, viral hepatitis can do that, pregnancy, Fanconi's anemia. It can be an idiopathic form as well. Now, ineffective hemopoiesis because of where the situation is that of bone marrow failure in the presence of a normal or increased bone marrow cellularity. And the common culprits is myelodysplastic syndromes and paroxysmal nocturnal hemoglobinuria, which is complement-mediated red cell lysis, problem with your GPI anchors on the red cell membrane. Infiltration has to do with leukemia, lymphoma, myeloma, granuloma, myelofibrosis. TB is an important form of bone marrow infiltration, especially when it's disseminated. Then the next cause of normocytosis is anemia of chronic disease, chronic inflammation from whatever cause, usually infection, can be abscess or TB, connective tissue disease, malignancy, endocrine deficiencies, hypothyroidism, Addison's disease, liver disease, CKD because of lack of erythropoietin and malnutrition. Hemolysis is extracorpuscular. We'll talk about that. So this is a beautiful approach to anemia taken from algorithms for differential diagnosis. So if you've got a clinical history of findings to suggest blood loss or hemolysis, then you go straight down here and you attribute your anemia to either blood loss or hemolytic anemia. But if you don't really have that clinical history or exam findings to support hemolysis or hemorrhage, then you do a corrected reticulocyte count. That's a nice place to start. If your retic count is less than 2.5%, that's an inadequate bone marrow response, right? And then you look at your mean cell volume. If it's microcytic, most likely a maturation defect. If it's macrocytic, you're speaking to a maturation defect. If it's normocytic, most likely a proliferation defect. But if your retic count is above 2.5%, that bone marrow is fully functional. Mwah, magnifique. Then if there's a clinical history of bleeding, you can say it's blood loss, and investigate the genitourinary or the gastrointestinal tract. But if there's hemolysis and the key indicators on your labs for hemolysis, where you have symptoms of hemolysis, the patient will be jaundice. And if you have an unconjugated hyperbilirubinemia together with a raised lactate dehydrogenase and a low haptoglobin, you can say most likely it's hemolytic anemia, right? So now if you're dealing with microcytic anemia and you know your MCV is less than 80 femtoliters, your tick count is going to be low. You do your full blood count, your peripheral blood smear, and your iron studies. Now, when your ferritin is below 30 microgram per liter, which is low, and your transferrin sats below 16%, reliably these are indices which indicate iron deficiency. You look for a source of blood loss, genitourinary, gastrointestinal tract. But if the iron studies don't support iron deficiency, ask, is there a suspicion? Could this be? Does it smell like? Does it quack like thalassemia? So you got clinical features of thalassemia, right? And there we have the chipmunk faces and frontal bossing and so forth, right? If your mean cell volume is below 60, so very, very low, and your Mensa index is less than 30, you can also look at your red cell distribution with, which is going to be low compared to iron deficiency, where you have poikilocytosis and anastocytosis, and that's going to be high in iron deficiency. But if MCV is low with a low red cell distribution with a Mensa index below 13, you want to do a hemoglobin electrophoresis and genetic testing. But if the answer is no, most likely this is anemia of chronic disease. The other two possibilities is cerebrospastic anemia and lead poisoning, right? However, if you're looking at macrocytic anemia now, right, you want to exclude reticulocytosis first up, where the bone marrow is churning out extra red blood cells very quickly, and those red cells are immature and they form reticulocytes. So often on the count of hemolysis, hemorrhage, or I had one other thing. Anyway, so you want to look at the tick count, which is usually going to be low, and you do your B12, folate, liver function, thyroid function. Why? Because B12 and folate deficiency cause megaloblastic macrocytic anemia. Chronic liver disease, alcoholism also causes macrocytic anemia, non-megaloblastic, and hypothyroidism as well. So your eventual answer will be B12 folate deficiency, alcohol, liver disease, hypothyroidism, drugs. Consider myelodysplastic syndrome as a diagnosis of exclusion. Now, the situation in normocytic anemia, guys, when your mean cell volume is between 80 and 100 femtoliters, right, then what you do is this a hyperproliferative state? Is this a leukoerythroblast picture? Is this isolated anemia, or is this pancytopenia? So this is isolated anemia, and you got the very low reticulocyte count. Consider red cell aplasia, right? If your reticulocytes are not low, ask yourself, is there renal impairment or hypocalcemia? In which case, you want to consider chronic kidney disease or myeloma. You know, the features of myeloma are hypercalcemia, renal impairment, anemia, and bone affectation, right? But if the answer to this is no, then you're probably dealing with early iron deficiency, anemia of chronic disease, or idiopathic. But if the situation is that of pancytopenia, do your peripheral blood film. If there's schistocytes, you can say most likely this is a microangiopathic hemolytic anemia, a MAHA, or it could be disseminated intravascular coagulation. If you see blasts, it's probably leukemia. If it's a leukoerythroblastic picture, it's probably infiltration of the marrow. And then on history and examination, do your B12 and folate as well. Is there a contribution from megaloblastic anemia? Is it cirrhosis? Is it medications, autoimmune disease, or infection? If these are unrewarding, you want to do your serology for viral and autoimmune contributing factors, and you want to do a bone marrow aspirate and trephine and diagnose aplastic anemia, myelodysplasia, or myelofibrosis. Okay. Now, just focusing now on hemolytic anemia, guys. Remember, we said that you got evidence of hemolysis, so you got an unconjugated hyperbilirubinemia. You got a raised lactate dehydrogenase, right? And you got a haptoglobin, which is low. And if there's no, okay, so this is the first stratification, the first departure point. Is the history suggestive of a cause, right? So look at history, suggested diagnosis, and further testing. So if you got hemolysis during or after a blood transfusion, most likely this is a hemolytic transfusion reaction. Check for ABO mismatch, right? And check your direct Coombs. If it's episodic hemolysis triggered by oxidative stress, you're thinking about favism, right? Glucose 6-phosphate dehydrogenase deficiency, and check your enzyme activity. If it's a septic patient, if it's malaria, do your thick and thin blood films, establish your parasite density, and treat with artesunate or with its cousin. I forgot the name of that drug. Coartem, yeah. If it's TTP-HUS or DIC, if it's a MAHA, do your prothrombin time, partial thromboplastin time, so your INR, your platelets, fibrinogen, D-dimer. This is your DIC workup, right? If it's hemolysis from childhood with a family history, thinking about congenital causes, to this end, do hemoglobin electrophoresis for thalassemia, peripheral blood film, other specific tests. If it's classic thalassemic facies, thalassemia, hemoglobin electrophoresis. If it's hemoglobinuria with unusual site thrombosis, thinking about paroxysmal nocturnal hemoglobinuria, do your flow cytometry. If it's a prosthetic valve with regurgitation, it's probably mechanical valve thrombolysis, but if hemolysis rather. But if there's no obvious cause, do a direct Coombs test. If it's positive, you're probably dealing with either a hemolytic transfusion reaction or this is autoimmune hemolytic anemia. Right? If you do your direct antiglobulin test, C3 only, it's probably cold autoimmune hemolytic anemia, but if it's IgG with your C3, it's probably warm autoimmune hemolytic anemia. And then you do your blood film. If you see schistocytes, platelets are normal, this is mechanical hemolysis. If you've got diminished platelets and your DIC workup is positive, that means that your INR is prolonged, your D dimer is prolonged, and you have diminished fibrinogen, it's probably DIC, disseminated intravascular coagulation. But if those parameters are normal, being your INR, PTT normal, D dimer normal, fibrinogen normal, most likely TTP-HUS, thrombotic thrombocytopenic purpura with or hemolytic anemic syndrome. Okay, if you've got characteristic congenital hemolytic anemias, then you look, and this you basically determine on your smear. If it's spherocytes, it's likely hereditary spherocytosis. So you do your EMA binding test. EMA is eosin 5 maleimide test. If it's sickle cell anemia, then you do your high performance liquid chromatography. If it's thalassemia, especially in so if you see spherocytes, it's hereditary spherocytosis. If it's sickle cells, think it's sickle cell anemia. If it's microcytic hyperchromic, right, especially with a very low red cell distribution with a Mensa index less than 13, you're thinking about thalassemia, hemoglobin electrophoresis. Alrighty. So here, guys, we're just looking at this graph which demonstrates for us our serum ferritin levels as a function of sex and age. So iron store depletion and iron deficiency are accompanied by a decrease in serum ferritin level below 20 microgram per liter, right? So here we're looking at age on the x-axis and serum ferritin on the y-axis, and we can see that in general, the serum ferritin is going to be higher in males than in females, and this is often because of menses, right? And store depletion occurs here at a level of about 20 microgram per liter, which indicates your depletion of iron and your ferritin is going to be lower in females compared to males as they progress and become older. Okay, this is a beautiful table, guys. Remember we said the differential for microcytic anemia is tails, okay? Thalassemia, anemia of chronic disease, iron deficiency, lead poisoning, and sideroblastic. But here we're comparing head-to-head iron deficiency with anemia of chronic inflammation with thalassemia with sideroblastic. So on this smear, iron deficiency, you're going to see typical microcytic hypochromic anemia, poikilocytosis, and algocytosis is a typical picture. You may have pencil cells. Inflammation will just give you normal parameters in the MCV. Thalassemia will give you microcytic hyperchromic anemia, but the key thing is target cells. It's variable in sideroblastic. Your serum iron and iron deficiency is typically low. The TIBC is high. Your percent saturation of transferrin is very low, less than 10%. Your ferritin is very low, less than 15 microgram per liter, and the hemoglobin pattern electrophoresis is normal. Versus anemia of chronic inflammation, where your serum iron is low, but not as low as in iron deficiency. Your TIBC is less than 300. That's important. Percent saturation of transferrin is between 10 and 20%. Ferritin is between 30 and 200. And hemoglobin electrophoresis is normal. In thalassemia, in addition to the target cells, you have a normal to high serum iron, a normal total iron binding capacity, transferrin SAS between 30 and 80%, ferritin between 50 and 300, and abnormal hemoglobin electrophoresis. Right, can be normal with alpha thalassemia, but not with beta thalassemia. Sideroblastic anemia is variable on the smear. Serum iron is normal to high, TIBC normal. Your percent saturation 30 to 80%. Your ferritin is normal, and you got normal hemoglobin electrophoretic pattern. Here, guys, we're just having a look at internal ion exchange. It's a beautiful picture from Harrison. So it says normally 80% of iron passing through the plasma transferrin pool is recycled from senescent red cells. Absorption of about 1 milligram per day is required for diet in men, from the diet in men, and about 1.4 milligram per day, slightly higher in women because of menses, right, to maintain homeostasis, or homeostasis rather. As long as transferrin saturation is maintained between 20 and 60% and erythropoiesis is not increased, use of iron stores is not required. However, in the event of blood loss, dietary iron deficiency, or inadequate iron absorption, up to 40 milligram per day of iron can be mobilized from the iron stores. Okay, here we're looking at causes of iron deficiency. If you have established microcytic hyperchromic anemia with iron deficiency in your iron studies, transferrin SATs are low, your serum iron is low, your ferritin is low. It could be due to increased demand for iron, increased iron loss, or decreased iron intake or absorption. So causes of increased demand for iron can be rapid growth in infancy or adolescence, pregnancy, and erythropoietin therapy. Increased iron loss can be chronic blood loss, menses, acute blood loss, blood donation, phlebotomy, as for polycythemia, decreased iron intake or absorption if there's inadequate diet or malabsorption from disease. Typical examples is tropical sprue, bacterial overgrowth, Crohn's disease, malabsorption from surgery in the way of gastrectomy or some forms of bariatric surgery, acute chronic inflammation. Guys, just draw attention to erythropoietin therapy. In patients with chronic kidney disease, we have to replete our iron stores, right, before we give EPO, and usually our target hemoglobin between 11 and 12 before we give erythropoietin. Okay. Here we're looking at suppression of erythropoiesis by inflammatory cytokines, which underpins the pathobiology of anemia of chronic inflammation. Now, through the release of tumor necrosis factor and interferon beta, neoplasms, and bacterial infections, all of these suppress endogenous production of erythropoietin and the proliferation of your erythroid progenitors by inhibiting your erythroid burst-forming units and colony-forming units. The mediators in inflammation in these patients with vasculitis and rheumatoid arthritis is interleukin-1. So we have our good friends interferon beta, interleukin-1, example from rheumatoid arthritis, interferon gamma, and they suppress bone marrow progenesis and hence decrease red cells. Okay, now looking at the hypoproliferative anemias, and we're just comparing them head to head in terms of our parameters, right? So in iron deficiency, we said it's mild to severe anemia with a mean cell volume between 60 to 90. Morphology is normal through to microcytic, right? And your serum iron is maybe less than 30. Your TIBC is high. Percent saturation of transferrin is low. We said the serum iron is less than 15. Iron stores, nada. But in anemia of chronic inflammation, it's mild anemia, MCV between 80 to 90, so it's a normocytic anemia. With the serum iron being less than 50, TIBC is lower than iron deficiency. Your percent saturation and your ferritin usually higher than iron deficiency. Iron stores, you got some iron. In renal disease, the anemia is multifactorial, but the main driving force is lack of erythropoietin production, right? There's mild to severe anemia with a normocytic anemia. Serum iron, TIBC, percent sats is normal, ferritin is normal, you got some iron in the stores. Hypometabolic states, where it's a normocytic anemia and all other parameters are essentially normal, okay? Here we're looking at disorders of hemoglobin itself, right? Where we split them into hemoglobinopathies, you got your thalassemias, you got your hereditary persistence of fetal hemoglobin and acquired hemoglobinopathies, all right? And the hemoglobinopathies are basically, you got your hemoglobinopathies, you got enzymopathies, membranopathies, etc., right? This is a beautiful diagram showing us the beloved hemoglobin oxygen dissociation curve. Now, the hemoglobin tetramer can bind up to 4 molecules of oxygen in the iron-containing sites of the heme moiety. Now, as oxygen is bound, 2,3 biphosphodiesterate and carbon dioxide are expelled. Salt bridges are broken and each of the globin molecules changes its conformation to facilitate more oxygen binding. Oxygen released to tissues is the reverse process, with salt bridges being formed and 2,3 biphosphodiesterate and CO2 bound. Deoxyhemoglobin does not bind oxygen efficiently until the cell returns to conditions of higher pH, the most important modulator of oxygen affinity. That's what we call the Bohr effect. When acid is produced in the tissues, the dissociation curve shifts to the right, facilitating oxygen release. Alkalosis has the opposite effect, reducing oxygen delivery. So here we're plotting tissue oxygen versus percent saturation of hemoglobin. Shift to the right would favor oxygen offloading from hemoglobin, right? And the factors involved are these. And the mnemonic is cadet. C is CO2, A is acidosis, D is 2,3 diphosphoglycerate, or biphosphoglycerate. E is exercise and temperature, right? So when your pH goes down in the setting of acidosis, and if you have increased 2,3 biphosphoglycerate and your temperature is lowered, then it favors offloading and more oxygen can be delivered. The opposite effect, if there's alkalosis, if there's diminished 2,3 biphosphoglycerate, if there's a temperature change, then less oxygen is delivered, and there's going to be a left shift in your hemoglobin oxygen dissociation. Guys, let's talk about causes of megaloblastic anemia. So we already touched on these, but cobalamin deficiency or abnormalities of cobalamin metabolism, folate deficiency or abnormalities of folate metabolism, therapy with antifolate drugs, the key drug being methotrexate. And then we have factors independent of either cobalamin or folate deficiency and refractory to therapy, Example, some causes of acute myeloid leukemia, myelodysplasia, therapy with drugs interfering with DNA synthesis like hydroxyurea, orotic aciduria, and thiamine responsive states. Okay, and these are the causes of cobalamin deficiency which are sufficient to cause a megaloblastic anemia. Malabsorption, pernicious anemia with its antibodies against your intrinsic factor producing parietal cells in the gastric antrum. Gastric causes in the way of congenital absence of intrinsic factor or functional abnormality, total or partial gastrectomy. Intestinal causes being intestinal stagnant loop syndrome, ileal resection, Crohn's disease, selective malabsorption with proteinuria, tropical spree, fish tapeworm, which is diphyllobothrium latum, we said that, and transcobalamin 2 deficiency. Causes of folate deficiency by and large, guys, I mean, there's a whole truckload of them. Dietary, malabsorption because of deficiency or because of the major and minor cause of deficiency, excess utilization or loss physiological, and then we have pregnancy, pathological like heme disease, malignancy, inflammatory disease, especially TB, psoriasis with this rapid cell turnover, metabolic disease like homocystinuria, excessive urinary losses, hemoperitoneal dialysis, antifolate drugs we spoke of, and mixed causes, all right? Guys, how do we classify hemolytic anemia? So divided according to intra and extracorpuscular. Intracorpuscular defects can be inherited or acquired. So the inherited intracorpuscular defects, hemoglobinopathies, enzymopathies, and membranopathies, right? Acquired causes, the poster child is paroxysmal nocturnal hemoglobinuria, which is complement-mediated red cell lysis. There's a problem with the GPI anchors on the red cell membrane on the surface of those, and we have activation of complement and red cell lysis and destruction. You got to send for flow cytometry, right? And extracorpuscular factors inherited can be familial hemolytic anemic syndrome and acquired being mechanical destruction, what we call a MAHA, microangiopathic, toxic agents, drugs, infectious, and of course autoimmune. So guys, how do patients present with anemia? Well, you want to evaluate whether it's acute or chronic or long-standing, right? Kind of grumbling, long-standing, chronic. You want to rule out active or recent bleeding, associated symptoms, and medical conditions or drugs that may contribute to the anemia. You want to evaluate for medications that can induce hemolysis, myelosuppression, or bleeding. Evaluate for signs of bleeding, stools for occult blood, ecchymosis or bleeding from sites of recent procedures and punctures, volume depletion or systemic illness. Symptoms of anemia may include diminished exercise tolerance, so easy fatigability, dyspnea on exertion, dyspnea at rest, and of weakness and lightheadedness. Signs include pallor, subconjunctival pallor, nail bed pallor or palmar pallor, bounding pulses, tachycardia, and confusion. Hemolytic anemia may lead to steral icterus and jaundice because of the high unconjugated bilirubin. Patients may present with heart failure, angina, or acute MI. Differential diagnoses for raised red cell destruction include inherited hemolysis in the way of G6PD deficiency, hemoglobinopathies, phagocytosis, acquired hemolysis on account of liver or autoimmune disease, infection like malaria or babesiosis, sepsis, hypersplenism, hemolytic anemic syndrome, lead toxicity, ABO incompatibility. Differential for diminished red cell production due to bone marrow suppression, nutrient deficiencies, alcohol use, low erythropoietin level, hypothyroidism, hypogonadism, blood loss, which can be overt or occult, or of course sickle cell disease. So how do we work up patients with anemia, guys? Lab evaluation in the emergent setting includes full blood count, reticulocyte count, stool for occult blood testing, comprehensive metabolic panel, blood typing, type and cross. On the full blood count, you pay attention to the mean cell volume and the red cell distribution width to evaluate your possible etiologies. Now, more comprehensive evaluation necessary in difficult cases. Remember, we said hemolysis, we have a raised LDH, diminished haptoglobin, do your smear, liver function, and Coombs to tell you whether it's an autoimmune process, warm and cold autoimmune hemolysis we spoke about. Iron studies, the parameters we looked at with the serum iron, the percentage transferrin saturation, your TIBC, total iron binding capacity, and your ferritin, right? And you want to calculate or determine your corrected reticulocyte percentage, and what you do to get this, the formula is multiply percent reticulocytes by hematocrit and divide by 45 to correct for the abnormal hematocrit. Greater than 2% or 2.5% suggests hemolysis or acute bleeding. So accelerated red cell destruction, essentially. Hemoglobin electrophoresis and bone marrow examination may be warranted. If you do suspect ongoing bleeding, evaluate the GI tract with endoscopy or colonoscopy. Also, good idea to investigate the genitourinary tract with a pelvic ultrasound and a pap smear as well. Hemolytic anemia may present with, we said, decreased haptoglobin, raised LDH, increased indirect bilirubin, increased urine hemosiderin, and a positive Coombs test if it's autoimmune in etiology. Macrocytosis with target cells speaks specifically to liver disease. In terms of diagnostic evaluation, guys, your peripheral smear may reveal multilobulated neutrophils and ovalocytes. That is an indicator for vitamin B12 or folate deficiency. Schistocytes in the setting of a MAHA, such as TTP, HUS, DIC, or mechanical valve hemolysis. Spherocytes in the way of an immune hemolytic anemia or hereditary spherocytosis. Let's have a look at some peripheral blood smears, guys. This is beautiful, taken from Talley and O Connor. Sorry, this is taken from Harrison's. So in A, we see the peripheral blood smear and severe megaloblastic anemia, the typical multi-lobulated nucleus in the neutrophil, and the typical macrocytic appearance of our red cells. In B, we see bone marrow in severe megaloblastic anemia, very large cells, multi-lobulated nucleus of the neutrophils again, very large macrocytes, okay? This is taken from Talley and O Connor. We can appreciate in the first portion, figure 22.2, hereditary spherocytosis or autoimmune hemolytic anemia. The numerous red cells we see are small, round, and lack central pallor and are spherocytes. The big ones are probably reticulocytes here. In image, the second one in the middle, we have cold hemagglutinin disease with clumping of the red cells, which I'm sure we can appreciate. Here we have frequent fragmented, bitten so-called red cells, yeah, which speaks to a MAHA. So these are schistocytes, okay, in the setting of disseminated intravascular coagulation. Here we're looking at sickle cell anemia, right? So I'm sure we can see the sickles, right? Film shows several sickle. There's a sickle. There's a sickle. There's a sickle. Sickle-shaped cells with target cells, probably secondary to autosplenectomy that occurs in sickle cell anemia. Leukoerythroblastic film here, the film is indicative of marrow infiltration. It shows circulating nucleated red cells. Okay, we have some nucleated red cells and immature white blood cells. Okay, very large immature. Here's a post-splenectomy picture with several Howell Jolly bodies. Right, these are our Howell Jolly bodies we have here, which are remnants of DNA, I think, okay, together with target cells and crenated cells. Myelofibrosis here, okay, let's look at the slide on the left, which shows dysplastic nucleated red blood cells, frequent teardrop poikilocytes, and a primitive granulocyte. Malaria in the middle shows two red blood cells in the center showing a beloved trophozoite, the ring form. Okay, and here we have viral illness on the right, which shows two atypical or switched on lymphocytes, diapedesis happening there, okay. Here we have bacterial infection like pneumonia, etc. And sepsis with the white cell in the center is a band form with, you can see the toxic granulation right there, right? Sorry about that. Acute leukemia in the middle slide, the film shows two very primitive white cells, progenitor cells with prominent nucleoli. And here we have iron deficiency. Red cells are varying in shape and size. So it's varying in shape, being poikilocytosis, and size anastocytosis, and very small and hypochromic. Guys, treatment and management. Treatment of anemia depends on acuity and etiology. Consider transfusion of red cells if the patient's symptomatology outweighs the risk of transfusion. Risk of transfusion, of course, being transmission of infection, transfusion reaction, iron overload. Patients with symptomatic anemia or coronary artery disease or those scheduled for surgery should be transfused with packed red cells with a goal hematocrit of above 30%. Each unit of packed red cells generally raises the hemoglobin by 1 to 1.5 milligram per deciliter and hematocrit by 3%. Now, special care must be taken in patients with known coronary artery disease because compensatory tachycardia may result in a so-called physiological stress test and subsequent demand ischemia. These patients should be transfused very slowly, 4 hours per unit of blood, usually give a dose of Lasix halfway through. Acute gastrointestinal blood loss may be a medical emergency and requires emergent endoscopy. Heme-positive patients with stable hematocrit and no symptoms may be considered for outpatient endoscopy. Now, once the patient is stabilized, the focus should now shift to correcting the underlying etiology. Patients with chronic anemia should be worked up as above to assess with the underlying etiology and guide therapy. Treatment measures include iron supplementation if iron deficient, hydroxyurea in sickle cell disease, erythropoietin in chronic kidney disease. Just looking at the various types of oral iron preparations, there's ferrous sulfate, there's ferrous fumarate, there's ferrous gluconate, there's polysaccharide iron. There's also IV formulations you can use. Locally, we have Cosmofer and Venofer. The advantage of Cosmofer over Venofer is that it's a stat dose. However, the cost factor is that Cosmofer is more expensive than Venofer. Venofer is usually 3 doses given every alternate day for 3 days, or for 3 doses, right? So you give it over a week. Guys, let's look at prognosis and complications. Prognosis depends largely on the underlying etiology and acuity. Elderly patients have a higher risk of mortality when the hemoglobin drops below 13 in men and below 12 in women. Patients with acute MI and hematocrit less than 30% have a decreased 30-day mortality if they receive a transfusion early during their hospital course. In the ICU, evidence supports blood transfusion for euvolemic patients who have a hemoglobin below 7. Try and maintain the HB between 7 and 9. Also, the Surviving Sepsis campaign recommends transfusing patients with a hemoglobin below 7. Okay, guys, coming back to our clinical case, we had a relatively young female, right, who's known with IBD, which has been relatively well controlled on infliximab. Her HB dropped from 11 to 8, but her heme was negative. Her stool was heme negative, and her serum iron and ferritin, which were normal previously, are now both low, and the smear definitely indicates iron deficiency. We saw anacytosis, poikilocytosis, we saw pencil cells, okay? So the peripheral blood smear is consistent with hypochromic microcytic anemia, the differential being tailed, thalassemia, anemia of chronic disease, iron deficiency, lead poisoning, stereoblastic. It was a case of anemia of chronic disease versus iron deficiency, but this patient had unequivocally low iron and low ferritin, consistent with iron deficiency. Okay, my friends, please allow me to encourage you from the Bible. The Apostle Paul says in the book of Ephesians chapter 4, verse 25, therefore, put away lying. Let each one of you speak truth with his neighbor, for we are all members of one another. Proverbs 12:22 says, lying lips are an abomination to the Lord, but those who deal truthfully are his delight. Lying is one of the simplest sins that one can commit. And sometimes we have this concept of white lies. No, beloved, there is no such thing as white lies. Lying is lying, and that's deception, and that constitutes sin. And when the Holy Spirit fills us, he is a spirit of truth. And I pray that we will be truthful in all our associations, interactions, and conversations. Here are my references, guys. Today was a bit of a mouthful with anemia, but it's quite a comprehensive topic. If you enjoyed this video, I strongly encourage you to subscribe to my channel, like and share my videos. Thank you so much. We've got some exciting topics coming up, guys. Looking forward to seeing you on those. God bless you. Have yourself a fantastic day.